the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Greetings to one and all. I am Dr. Pavandeep Kaur. I am an assistant professor in the Department of Musculoskeletal and Sports Physiotherapy at Sancheti Institute for Orthopaedics and Rehabilitation, Pune. For today, we'll be studying the topic of brachial plexus injuries, and this topic is going to be covered in two seminars. So, in the first seminar, which is today, we'll be learning about the anatomy and its application to brachial plexus injuries. Then, what are the causes of brachial plexus injury? Then, the classification of brachial plexus injuries, and the most commonly seen two types of injuries will be covered in first part. And in the second part, we'll be learning about the clinical examination, the assessment, the method of management, which can be surgical as well as physiotherapy conservative management. So we'll be discussing those details in the part 2 of this video. So, as I said, the topic for today is brachial plexus injuries. So, brachial plexus is located, it's a network of nerves which is located in the neck area. So, it's the roots which are C5, C6, C7, C8, and T1. They originate from the spinal cord and they are distributed, the nerves are distributed from the neck and they go down and supply the upper limb muscles. So, the proximally, the brachial plexus has proximal location, and proximally there are the scalene muscles, and distally you will see the clavicle and the pectoralis muscle. Talking about the anatomy of brachial plexus, now we have studied this before, in which the roots are C5, C6, C7, C8, and T1. So the nerves originate from the roots and then they divide into So they divide into trunks, divisions, cords, and branches. So overall, the plexus consists of roots, trunks, divisions, cords, and branches. Now the roots are constituted by the anterior primary rami of spinal nerves C5, C6, C7, C8, and T1. Now, if the C4 contribution is large and T2 is absent, it is called as a prefixed brachial plexus, and it is postfixed when the T1 and the T2 contribution is large and C4 and C5 are reduced. C4 is absent and C5 is reduced in size. Next is the trunk. So after roots, we will discuss about the trunks. The C5 and the C6 form the upper trunk. C7 forms the middle trunk, and the C8 and T1 form the lower trunk of the plexus. Further, the trunks are divided into divisions, and each trunk has ventral and dorsal division. Ventral is also called as an anterior division, and the dorsal division is also called as a posterior division. So, these are the further two classifications. After divisions, we'll be studying about the cords. So, the divisions of the trunk join to form the cords. Now, the ventral division of the upper trunk and the middle trunk will form the lateral cord. The ventral division of the lower trunk will form the medial cord, and the dorsal divisions of upper, middle, and lower trunk will form the posterior cord. Further, the cord is divided into branches. So, this is very important and this is used clinically also. So, the branches of the roots are long thoracic nerve, which is formed by the roots C5, C6, C7, which supplies the serratus anterior muscle, and the dorsal scapular nerve, which has a root value of C5, supplies the levator scapulae and the rhomboids. So, if the injury is at a higher level, so we can suspect that these two muscles will be the first muscles to get involved, and as they originate from the root. Talking about the branches of the trunk, now they arise only from the upper trunk. So they are suprascapular nerve, which is formed by the root of C5, C6, and the nerve to the subclavius, again C5, C6. So basically the suprascapular nerve supplies the supraspinatus and the infraspinatus muscle, and the nerve to the subclavius supplies the subclavius. Talking about branches of the cords. So, first is the branches of the lateral cord. They are lateral pectoral nerve, C5, C6, C7, then musculocutaneous nerve, which is C5, C6, C7, and lateral root of median nerve, which is C5, C6, C7. So basically, your lateral pectoral nerve supplies the pectoralis major and the pectoralis minor muscle. The musculocutaneous nerve supplies the biceps, brachialis, and the coracobrachialis muscle. The lateral root of median nerve again has innervation, so it supplies the flexor muscles of the hand. Talking about the branches of the medial cord, they are so the medial pectoral nerve, which has a root value of C8T1, medial cutaneous nerve of the arm, which has a root value of C8T1, medial cutaneous nerve of the forearm, and ulnar nerve and medial root of the median nerve. So it's very important that we know that the ulnar nerve is a branch of the medial cord. Now the branches of the posterior cord. So first one is the upper subscapular nerve, which has a root value of C5, C6. Then the nerve to the latissimus dorsi, which has a root value of C6, C7, C8. So it's also called as a thoracodorsal nerve. Then the lower subscapular nerve, which has a root value of C5, C6. Axillary nerve, which has a root value of C5, C6, which supplies primarily the deltoid and the teres minor muscle. And the radial nerve, which has a root value of C5, C6, C7, C8, and T1, and supplies all extensor muscles of the forearm and the arm. So, up to now, we have just studied the anatomy. The plexus consists of, first originates from the roots C5, C6, C7, C8, T1, which form the trunk, okay, upper, middle, and lower trunk, which further divide into divisions, which is dorsal division and ventral division. Now, after the divisions, there is further classification where they form the cords, the three cords, lateral cord, posterior cord, and the medial cord. And further they form branches, which give nerves and supply the muscles of the upper limb. Okay. So after studying anatomy, now let us learn what are the causes of the injuries. So most common injury, which is most common injury seen is due to trauma, which is a road traffic accident. So in this, you will see that the person, if the person is in a car and he is met with an accident, the head and the shoulder are separated to the opposite side, which puts a pressure on the brachial plexus, right? And this is the most common form of injury where the head and the shoulder are separated from each other. Usually, in cases we see that when a car hits a divider and the person falls off the car, so the head goes in one direction and the shoulder depresses. So basically, the head and the shoulder get separated from each other. So it puts a push on the brachial plexus. Then traction injuries, if there's excessive pull, then it can cause pressure on the brachial plexus. Also, if the hand gets stuck and it is in hyperabduction, then it can cause pressure during prolonged unconsciousness. Okay. Then talking about the post-radiation fibrosis, this is commonly seen when uh, after radiation. So there are patients who receive radiation therapy post breast cancer or any cervical lymphoma. So post that they receive radiation therapy. And brachial plexus injury is a long-term injury which is seen in these patients. So it's not like immediately after taking a radiation therapy, patient will develop a BPI, but when there is, it's like a residual effect. So it doesn't develop immediately after a prolonged duration of exposure to this radiation therapy. There is fibrosis of the nerves which are around the brachial plexus, which can put pressure, especially seen in cases where there is a cervical rib. So basically, following a cervical rib also, there is fibrosis which develops, which can cause pressure on the brachial plexus, right? Also tumors, if there is a pancoast tumor or any there is a tumor of the lung, so any lobular involvement is there of the upper lobes, it can put pressure on the brachial plexus and it can lead to a BPI injury. Then the next is the birth injury. So in cases of obstetric, like it's called as an obstetric PPI, and it is seen in shoulder dystocia. So what is shoulder dystocia? In this, the child is born. So first his head comes out, but one shoulder is stuck during the delivery. So the management which is done is they usually put a forceps and remove the baby out. But due to this, there is a strain which comes on the neck as the head and the shoulder are pulled in the opposite direction. So which puts a pressure and causes a BPM. Yeah. So this is a figure which is explaining the same. Now this tells first figure is about the how the brachial plexus gets stretched due to traction. Then the second is as there is foraminal narrowing, then there is sudden pressure which is put on the neck. So due to the head and the shoulder going in the opposite direction, there is a stretch just put on the plexus. And the other two figures talk about the upper brachial plexus injury and the lower brachial plexus. Now we'll be discussing about this in the further slides. Talking about the classification of brachial plexus injuries. Now primarily there are two main uh, types. One is a preganglionic lesion and the other is a postganglionic lesion. So what is a preganglionic lesion? Now if the level of lesion or the injury is proximal to the dorsal root ganglia, it is called as a preganglionic lesion. And if the nerve root is avulsed out of the spinal cord, there is a poor prognosis. Uh, then, if there is a postganglionic lesion, the lesion is distal to the dorsal root ganglion. Further, it is divided into two types. First is the lesion in continuity. So, if the nerve root and its sheath is intact, then you expect a spontaneous recovery. But if the nerve root is intact, but the sheath is ruptured, so you expect that the prognosis is not exactly, you can say it is not exactly poor, but yes, there is delayed recovery in such cases. To summarize this, there are two types of lesion. One is a preganglionic and the other is a postganglionic. Depending on where the injury is, if it is proximal to the dorsal root, it is called as a preganglionic lesion. And if it is distal to the dorsal root, it is a postganglionic lesion. Next, if the nerve root is avulsed out of the spinal cord, the prognosis is poor. Whereas if the nerve root and sheath are intact, as in a postganglionic lesion, there is spontaneous recovery. And if the sheath is damaged but the root is intact, then you expect a slower recovery. Yeah. Now this is the diagrammatic representation showing the how we divide the levels of BPM. So the level 1 here shows us a preganglionic lesion. So in this, if you see, the root is involved and it is avulsed from the spinal cord. So it has poor prognosis and it has a higher level of injury. Talking about the level 2, 3 and 4, these are postganglionic injuries which cause a stretch and a pull on the brachial plexus, but the region is distal to the dorsal root ganglia. Now, there are further classification of a postganglionic, whether it is a retroclavicular, that means whether it is a supraclavicular or an infraclavicular injury. Now, if the injury is retroclavicular, behind the clavicle, means the structures involved are behind the clavicle. So, it's called as a retroclavicular injury, and mainly the trunk and the divisions are injured in such case. And if it's a level 4, that means it's an infraclavicular injury. The cords and the terminal branches are injured. So this picture is very important because it's important to identify where the level of injury is, as our rehab and our further management depends on finding out whether the cord is involved, whether the branches are involved, trunks are involved, or divisions are. Okay. Now this figure gives us a brief idea about the injuries. So the first is a preganglionic, where you can see that there is an avulsion. So the nerve roots are come out of the cord. Whereas the postganglionic has two types, A and B. A is where there is a stretch on the nerve, but the neural sheath and the root is intact. B tells us that the root is ruptured. The root is intact, but the sheath is ruptured. So hence the recovery will be slower in B. Now, the another classification of a BPI is whether there is a complete involvement or a partial involvement of the brachial plexus. So, if it's a complete involvement, all the four roots are severed starting from C5 to T1. If it's a partial, then it may involve either the upper trunk, which is C5, C6, C7, or the lower trunk, which is C8 and T1. Okay. Yeah. So, depending on how to identify a preganglionic lesion. So we can ask the history, and the mechanism of injury will be a high-speed accident where the head is moved away from the shoulder. There will be a severe injury which can cause unconsciousness. Fractures can be present, and associated head injury may be present in these patients. The signs which we can pick up and identify it as a preganglionic are Horner's sign. So in Horner's sign, first there is ptosis. What is ptosis? Ptosis is drooping of your eyelid. Then meiosis. Meiosis means there's a constriction of your pupils. Anhidrosis is loss of sweating on the affected side. And loss of pilomotor response is that means the normal pilomotor response is that whenever there is a cold sensation or a hot sensation which is applied to the skin, the hair they stand erect of our skin. So there will be loss of the normal pilomotor response. The next important sign will be there is a typical crushing or there will be a sharp constant pain which will be present even at rest. So this is a very characteristic feature of a preganglionic lesion. Then next will be there will be a presence of high cervical scoliosis. So these are the typical signs which we see in a preganglionic lesion. Next are the clinical symptoms of a post-ganglionic lesion. So, depending on the history, um, the mechanism of injury here will be slow speed trauma, and the associated injuries may or may not be present. Signs here you will not see any honor sign or there will be any pain. Main sign will be a positive Tinel sign or the neuroma sign. Now, there are two regions. One is the site of the lesion, and the other is where you are seeing the point of regeneration. So, two Tinel signs will be present. The stronger distal lesion sign than the proximal indicates that there is an axonal regrowth and clinical recovery, right? So, this is a very important point and it has to be remembered. Next, now we'll be studying the upper plexus injuries. So, the first one here is an Erb's palsy. So, Erb's palsy is also called as policeman's tip hand or porter's tip hand. The site of injury here is a region in the upper trunk of the brachial plexus is called as a Erb's point, where six nerves meet. So, which are the six nerves? Now, the C5 has an anterior and a posterior division. C6 has an anterior and a posterior division. Then the nerve to the subclavius and the suprascapular nerve. So basically, these six nerves meet at a point in the upper trunk of the plexus, which is called as a Erb's point. And if there is an injury to this point, it is called as a Erb's palsy. Now, what are the causes of this? If there is an undue separation of the head due to a birth injury, fall on the shoulder, or during anesthesia. So, in such cases, we get an Erb's palsy, which is also called as the upper plexus injury. So, if your nerve root involved is C5, then which muscles will be paralyzed? The important muscle is biceps, deltoid, brachialis, brachioradialis, supraspinatus, infraspinatus, supinator, and teres minor, right? And if your nerve root C6 is primarily involved, then the muscles affected are ECRB and ECRL, which is extensor carpi radialis brevis and extensor carpi radialis longus. Now, what is the expected disability which we see in these patients? Main is inability to abduct and laterally rotate the arm at the shoulder, inability to flex and supinate the forearm, loss of wrist extension, deep tendon reflexes of biceps and supinator jerk are lost. Then the sensations are impaired over the outer border of the arm and forearm on both the anterior and the posterior aspect. And when the C6 is also involved, there's anesthesia which extends medially and also involves the thumb. Now, why it is called as a policeman's tip hand? Because your arm is hung by the side, the shoulder is adapted and medially rotated, and the forearm is extended and pronated. Now, there are two images given here. The second image is of the clinical picture of a Erb's palsy, and the first image is about the signs and symptoms which you see in a Erb's palsy. So, if it's a preganglionic, you'll see the Horner's syndrome, you'll see ptosis, and you will see meiosis. Then, the shoulder will be rotated forward. The affected arm will be diminished in length and girth. There will be wasting or atrophy of the affected arm. And since there's loss of wrist extension, it is the patient's wrist will be flexed. So it looks like a waiter's tip hand. From the posterior view, you will see cervical scoliosis, and due to paralysis of the serratus anterior, you will see bird winging of the affected scapula, and compensated lumbar scoliosis will be seen posteriorly. Yeah. So after studying about the upper trunk injuries, we'll be studying about the lower trunk injury of the brachial plexus. The cause of this injury is mainly undue abduction of the arm, which is seen in fall from a height and birth injuries. The nerve roots involved are T1 and partly C8. So if your T1 is involved, the intrinsic muscles of the hand, which are the lumbrical and the interossei, palmar and dorsal, will be weak. So basically, it will lead to affection of your grip. So your grip will be weak and hand function will be affected. And if your C8 is involved, the flexors of the wrist and the hand will be affected, which can further affect your gripping activity. Now, talking about the uh, disabilities which are seen, typically you will see a 8 thumb and a complete claw hand of your hand, and there will be thenar and hypothenar atrophy and wasting. Associated cutaneous anesthesia and analgesia in the narrow zone along the ulnar border of the forearm and the hand. There will be sensory loss of the forearm and the hand. There will be loss in the dermatome. Basically, C8 and T1 dermatome will have loss of sensations. Loss of sympathetic activity will be seen. There will be absence of sweat, which can lead to drying of the skin. And long standing, there will be dry and scaly skin. The nails will crack easily with atrophy of the pulp of the fingers. This is a deformity of the this thing, which is called as a claw hand, where there's wasting of the dorsal intrusion. So, stay forward. We'll be learning about the clinical examination, assessment, and management of such injuries in the next PhysioTV class.